Haberman, and I'm at the University of Florida in Gainesville. I'm part of the division of otology and neurotology. So what I wanted to talk about this morning was colesteatoma, but I wanted to actually center on the acquired colesteatomas, and in particular primary acquired colesteatoma and secondary acquired colesteatoma. And we'll talk about that. Now, there are some definitional things that we'll go through in a minute. But when you think about colesteatoma, this is probably I'll review for you, but it's a collection of keratinized squamous epithelium in the ear that could be a primary lesion or a secondary lesion. It has a couple of key characteristics where it's locally invasive and locally destructive. There's a lot of definitions about, well, what is or what isn't colesteatoma. For example, is a retraction pocket colesteatoma, is atelectasis or atrophy of the eardrum, is that colesteatoma? But there seems to be some very common characteristics that define colesteatoma. One of those is scutum erosion, which is we'll get into a little bit later. And with otomicroscopy, we're really able to get very good looks at the eardrum and surrounding structures and make better characteristics or better definitions of what we're seeing. So I want to make sure that we are clear about nomenclature. So primary colesteatoma, or synonymous, would be congenital colesteatoma. We don't really use the word primary colesteatoma much. Most of us will use the word congenital colesteatoma to describe that, which is the characteristic anterior superior middle ear finding of a colesteatoma pearl. But that's what this talk is not about, that necessarily. This is about acquired colesteatoma, and then specifically primary acquired colesteatoma and secondary acquired colesteatoma. So the incidence of colesteatoma is 4 to 6 per 100,000. More men, people of lower socioeconomic status, perhaps, and then underdeveloped countries. So those who see large numbers of immigrant population, for example, you might see more colesteatomas. In my career, I've had the opportunity to serve and treat different immigration or people that came in through Southeast Asia, and then Latin America, and then East Africa and West Africa. So over my career, I've seen a significant number of colesteatomas associated with different parts of the world and coming into the clinic. I spent most of my career in Minnesota, where I saw the vast majority of those patients. So now I'm at the University of Florida, and we also now see a broad array of people coming from not only from Florida, but the Southeast, and also from Latin America and the Caribbean. So this slide goes through current theories of colesteatoma formation. So there's 4 kind of theories out there, and there's retraction pocket, squamous metaplasia, squamous immigration, and then basal cell hyperplasia. But all of these theories will make sense to you. If you go through them one by one, they'll tend to start making sense about which is more likely, which is less likely. But this is just what's out there and reported. Usually the pars flaccida area for acquired colesteatoma is where we see this, but not always. So let's go through the different theories. You can see on the pictures on the right hand of the screen where the various theories are presented and in picture form. But retraction pocket is, of course, what we most commonly think leads to colesteatoma, where you have this chronic negative middle ear pressure from the eustachian tube dysfunction, and then you form retraction pockets in the pars tensa part of the eardrum associated with scutum erosion and a pocket formation. So over time, it'll close off, and desquamated keratin debris will then fill in this cyst and then you have cholesteatoma. So when we think about the most common kind of primary acquired cholesteatoma, which is what we're talking about here, this theory seems to be the most widely accepted. When you think about what you see in the clinic when people come in with cholesteatomas, you can see these areas of scutum erosion posteriorly, superiorly, and then you would think, oh yeah, definitely this is from this chronic negative pressure building up and causing this condition. The squamous metaplasia theory is with transformation of middle mucosa into keratinizing epithelium. So this has been described and discussed and talked about at length, but has really not been proven. So I think that the biggest problem is that the cholesteatoma is ectodermal, so which is different than mucosa. So we would think that that's probably not as likely as a theory. Squamous immigration theory, where the eardrum basically migrates through some sort of portal or perforation to enter the middle ear cavity. So when we get into the definition of a secondary acquired cholesteatoma, I'll kind of come back to this, because this is really more of a definition of secondary acquired than primary acquired. But there has been reports in the literature that you might have this sort of immigration of squamous epithelium being the source of a primary acquired cholesteatoma. The last bullet point was where the majority of cholesteatomas occur with intact eardrum. I'll discuss that with a photograph in a second. But I don't mean an entirely intact eardrum, but if you look at most of the eardrum itself will be intact with primary acquired cholesteatoma. Then finally, basal cell hyperplasia, where these keratin-filled microcysts or pseudopods invade then the subepithelial tissue of the Prozac space. So there may be some histologic specimens that support this, but again, I wanted to present what's been reported in the literature so you can have that for your reference. So secondary acquired cholesteatoma is epithelial migration into the ear through usually a perforated eardrum. And it's so you can think of secondary acquired cholesteatoma as basically secondary to some event. So something happened and then secondarily formed cholesteatoma. So infection, trauma, and iatrogenesis, for example, like an ear tube insertion or something like that. These are often associated with chronic inflammation. And then there's proliferation of epidermis in the middle ear. So if you think back of that squamous metaplasia theory we talked about earlier, it could be that actually secondary acquired cholesteatoma forms as a result of metaplasia, although I can't say that I have absolute proof of that. So, but in essence, you have primary acquired cholesteatoma, mostly thought to be due to chronic negative middle ear pressure. And then you have secondary acquired cholesteatoma as a result of some previous event. So that's how we kind of characterize acquired cholesteatomas. In the clinic, I try to differentiate these. So when I see primary acquired versus secondary acquired, then I would utilize that terminology in terms of my documentation. So there's pretty characteristic symptoms, clinical features of cholesteatomas, which are fairly expected. Some people present with non-specific otologic symptoms, but you would expect to see hearing loss, perhaps tinnitus. But one of the main ones, the thing that is characteristic of cholesteatoma would be foul-smelling purulent otorrhea that's painless. So we have to add that bullet point, painless. But so painless, foul-smelling purulent otorrhea is kind of like your classic kind of presentation of a cholesteatoma. Of course, you can have other symptoms too, like vertigo and facial nerve palsies and advanced cholesteatomas, which get a lot more attention, I think, than just otorrhea. If you think about the presentation of otorrhea in your clinic, you can think of all kinds of differential or things in the differential that you would think about. But painless otorrhea in particular seems to be the one that is most prominent. So hearing loss, of course, is present with colesteatoma, and that can be quite interesting in the clinical setting. When you think about primary acquired colesteatoma, you think, well, this is going to take a while for this to happen. It can erode ossicles. It could even erode into the inner ear through the cochlea or into the cochlea, causing sensory neural hearing loss. And then secondary acquired colesteatoma, they probably already have some element of hearing loss anyway. And then when you add the colesteatoma on top, then you're probably going to be saying, well, there's actually progression or worsening of the hearing loss. But one of the challenges, clinical challenges that we have is, especially with primary acquired colesteatoma, is that if you have a large colesteatoma that basically has eroded the incus and the stapes superstructure and is sitting on the stapes footplate, you can have a situation where you have actually an intact drum over the colesteatoma with posterior superior erosion, and actually pretty good hearing. Those cases are quite challenging because the patient will come in with this history of otorrhea or situation with the other symptoms of colesteatoma, but then their hearing is pretty good, and they're asking me like, okay, well, what's going to happen to my hearing when you remove this? So we'll talk about that a little bit later with the surgical approaches to this, but it does present a significant challenge for us in trying to maintain or even improve on hearing results. Let me just see. I'm going to check something about the chat. If there's if anybody has any questions, they can send a chat message. I'll try to answer it at the time, or let me know, or just speak up. So in terms of the history, we talked a bit about history and review systems. Now, physical exam is basically otomicroscopy is the gold standard in terms of examination. As we move into this newer world of adding telemedicine, we haven't quite figured out all of that yet. Maybe you guys out there will figure out the best ways to do otoscopy if we do a telemedicine or with telemedicine. But when I see a patient in our clinic, our otology clinics, I mean, the first thing I'm going to do is get an outdoor history and review systems. I'm going to get a really good look with a microscope at their eardrum. Now, a lot of people use endoscopes as well, which can be absolutely fantastic. We have both capabilities. Sometimes I'll use endoscopes, sometimes I'll use microscopes, but most of the time I'll use a microscope and then try to characterize and describe in detail what I'm seeing. High resolution CT scan is very commonly done, but what I would say to you is that it's not 100% necessary in every single case. If you have a patient that comes into your clinic and they have a very characteristic history, past history of otitis media probably, and then a history of painless otorrhea that's foul smelling, and you look in their ear and they have scutum erosion and you can see obvious colesteatoma, you might move directly into treatment phase versus doing a high resolution CT scan. I would say in the vast majority of my cases, they either have a CT scan done by the time they see me, or will order a CT scan. Sometimes the diagnosis is obvious, the treatment is obvious, and we know what we're going to do, but we'll do the CT scan pre-op. So we have those situations as well. To save, some people come from a long ways away, so to save them time, we might order it the day that they're in clinic, or even if there's a day before surgery that they're going to be in the area, or even before surgery. So, but I can think of a few cases at UF where I've done tympanomastoid surgery without CT. And then in my career, I can think of many episodes or many times when I've proceeded without CT scanning. However, I would say to you that, and when you think about your physical exam and then what you're going to order for testing, you're going to do an audiogram and you're going to do a CT scan. That would be sort of the characteristic things you should think about doing. So otoscopy or otomicroscopy, where you can basically see the colesteatoma, or you can see where the lesion is, or see the retraction pocket. When we think about these definitions of colesteatoma, I've been in conferences where there's been lengthy debates about what is and what isn't a colesteatoma. I've heard people classify them as a retraction pocket where the depth cannot be determined, where if you took a large right angle pick and you place it into the pocket, you're not really able to appreciate the depth of that pocket. I mean, is that a colesteatoma, or do you have to have the local invasion, local destruction with a cyst to really make that diagnosis? I mean, I've heard this debate for many years in terms of, well, this is and this isn't a colesteatoma. I like the idea of where you can't really identify the extent of the retraction pocket as a colesteatoma. That's typically what I'll think about when I'm examining patients, or saying it is or isn't, versus an atelectatic eardrum or just a retraction pocket. I mean, typically the ear canal is clear, but not always. I mean, you can have situations where you have the drainage and then they have a secondary otitis externa. In fact, a lot of patients that will come into our clinic, or some patients will come into our clinic with a diagnosis of otitis externa when actually what they have is a colesteatoma. So, but when you're looking under the microscope, you can get an idea of the posterior superior quadrant erosion. And of course, they're pearly white structures. If you can see the pearly white structure in the posterior superior quadrant, and you have everything meeting history-wise, I mean, you basically have the diagnosis. So that's fairly straightforward. Well, this is kind of what I'm talking about. If you look at this photograph on the right, when you think about retraction pocket, so is that a colesteatoma, or is that not a colesteatoma? I mean, if you look at the yellow and the white arrows, I mean, you obviously see a fairly large retraction pocket with the head of the malleus. You can see the little red dot oval around the neck of the malleus. And so it's obvious that there's an erosive process going on. But is that colesteatoma, or is it not colesteatoma? What I'm saying is that if you reach with an instrument and you really can't appreciate the depth, then I would say, yeah, that's colesteatoma. I would agree that that would be colesteatoma. But you have cases that come in with maybe not quite as an extensive amount of scutum erosion, where you have some scutum erosion with a retraction pocket that you may say, okay, I'm really, maybe that's early colesteatoma, but I don't have to do anything right now. So that's one of those things clinically you have to make that determination. So high resolution CT scan is really what I talked about before is the gold standard. If you look at excluding colesteatomas with a well aerated cavity or a mastoid cavity, is that really give you the predictive value? Sometimes I would say that sometimes is true. So if you look, for example, we'll go back to that picture there, and then if you have a very well aerated mastoid, no evidence of a mass or no evidence of soft tissue, you would think more along the lines of retraction pocket versus colesteatoma. CT scans, though, also help plan your surgical approaches. You can look at the sigmoid sinus, you can look at the tegmen, you can look at the lateral semicircular canal, the facial nerve. All these things are extremely helpful in terms of the extent of the disease and with your planning for a surgical approach. I know that you guys are, I think, mainly residents, or most all residents, so you've seen plenty of CAT scans. But here's kind of an example of this axial view. And then if you look medial to the head of the malleus, you're kind of seeing some air. And then lateral to the malleus, you see the soft tissue. So to me, when I look at something like this, I'd think, okay, you have a process going on. It's not eroded through the head of the malleus yet, but you have some extension into the mastoid, probably the antrum. It could be colesteatoma. It could be soft tissue mucosal thickening or something like that. But when you look at these scans, what I look at especially is that if I see these areas of aeration around soft tissue, and if I see sort of a demarcation of the soft tissue from the aeration, I'm thinking, oh, okay, so there is a mass there. There is something to be more concerned about. So I would think more colesteatoma versus inflammatory disease only without colesteatoma. So we'll talk about second stage ear surgery shortly, but diffusion-weighted MRI scan has really come along to reduce the likelihood of requiring second stage or second look surgeries. I use it quite frequently now with our patients, even in the most severe cases of initial or where the colesteatoma is very extensive. If I feel as if the surgery went quite well, I offer diffusion-weighted MRI scan to look to see if there's evidence of more colesteatoma. So I feel the test is very helpful these days. This is just a photograph just showing where it lights up and you think, okay, there you go. You have more. I have a lot of cases where I'm convinced, I'm almost 100% convinced there's going to be a lot more. And we do these MRI scans and there isn't. So then I will continue to watch those cases. And then I also have situations where I think, no way, there's not more colesteatoma, and I'm wrong. So there is colesteatoma. Of course, there's other things too that can happen in the middle ear or mastoid, probably without the bony erosion you see in colesteatomas. Those are all listed, and it's just the kind of thing that you would expect. Cholesterol granulomas, mucoceles, granulation tissue, inflammatory tissue, edema, fibrosis, etc. And more, including tumors and cancers. So I've seen more benign tumors than I have malignant tumors, although a lot of the referrals that we get here are malignant, but over my career in particular, I've seen more benign tumors than malignant tumors. So if you make your diagnosis then of colesteatoma, then what I've learned and what I still say is basically a surgical disease. And when I say about controlling acute infections, what we're really doing is we're saying, okay, we're gonna stop your drainage. That's one of the goals. We're gonna remove the disease and control your drainage. You're not gonna have this purulent material coming out of the ear. So number one goal is to remove the disease, and number two goal is to restore and maintain hearing. So I have that conversation with patients all the time, which is you have a colesteatoma. Our primary goal is to remove it. It could be that we remove it and your hearing gets worse. It could be that we remove it and your hearing is a lot better, or it could be the same. But we need to first goal be to remove the disease. And most everyone that I treat, they understand that and they'll accept that. They've been dealing with this condition probably for many years, so it's something that they're not surprised to hear that they have it. Usually, when we talk to patients, we'll explain about colesteatoma, and the response is, yeah, I knew I had something going on. I mean, that's almost all the time we kind of hear that statement. So they're not surprised at all to find that they have something that needs to be taken care of surgically. Also, they're not surprised. They're not surprised to hear that their hearing may be worse, or could be better, or it might be the same. So a lot of times people will even make statements along the lines of, just get rid of the disease. I don't worry about my hearing, which may or may not be true really, but they're used to this condition. They know what it's about for them. So they're very happy to be able to know that there's a treatment plan. So when we talk about the infection associated with this, it's basically what you would expect in terms of organisms, Pseudomonas, Staph aureus, etc. Now, there's a whole separate talk that we could get into about suppurative complications of otitis media. I'm going to take a minute here to talk about the chronic otitis media paradigm. So when we think about chronic otitis media, it's basically a continuum of disease. I mean, you go from acute otitis media to where it transitions into more of a chronic state. And in children, of course, that's a separate discussion as well. But in the adult population, where you have persisting and recurring infections, usually with effusions, mucosal edema, mucosal disease throughout the medullary mastoid. And then you have, I like to categorize it, colesteatoma or chronic otitis media with colesteatoma and chronic otitis media without colesteatoma. So they're kind of different animals. The chronic otitis media with colesteatoma is what this talk is about and what I've discussed about surgical disease. And then if you take the whole separate segment of chronic otitis media without colesteatoma, that's a different thing. So, however, having said all of that, both conditions, chronic otitis media with colesteatoma, chronic otitis media without colesteatoma, can lead to these suppurative complications. So meningitis, acute mastoiditis, meningitis, brain abscesses, epidural abscesses, lateral sinus thrombosis, etc. So there's the thing to keep in mind is that you're probably more likely to develop, and I don't have I'd have to double check on this, with colesteatoma complications versus your chronic otitis media without colesteatoma complications. So getting cultures is something that I'll do. If people come in, a lot of times they've come in with multiple courses of antibiotics. They've been treated with cephalosporins, Augmentin, Cipro, oral Cipro, quinolone drops, all kinds of different things. So they come in, or antifungal treatment as well. Sometimes it's really helpful if you have like an acute flare-up where you can get a culture and you can identify an organism. You might be able to switch treatment to a more specific or treatment if it's based on cultures. However, a lot of times, if you're identifying colesteatoma, you're going to be moving the surgery, and the cultures may or may not be that helpful. So I would base it on what I'm seeing and what the history is, whether or not I'll do a culture. All right, so in the time that's remaining, Dr. Comer had mentioned that try to keep this to 30 to 40 minutes so that we have time for some interaction. So obviously this slide has canal wall up and canal wall down mastoidectomies. So for decades, I did an instructional course at the Academy on these techniques, a two-hour course. And then I didn't do it for a few years. We actually resubmitted it this year. So we'll see if it gets on again. But when you think about these approaches, there's canal wall up versus canal wall down. Historically, canal wall down mastoidectomy has been done for colesteatoma with very good results. So, and it wasn't until into the 60s and 1960s, 1970s when canal wall up mastoidectomy or tympanomastoidectomy was started to be utilized. And then when canal wall up mastoidectomy was utilized, there was a lot of debate in the otologic world because it seemed like you can't get colesteatoma out by leaving the canal wall up. You need to take the canal wall down to really get it out, which developed, and then surgical approaches were developed to open the facial recess. And when the facial recess was open, there was another avenue into the middle ear. And if you think about colesteatoma, I like to think about three areas where cholesteatomas can hide. the facial recess, the sinus tympani, and the anterior epitympanum. So with extended canal wall up techniques, opening the facial recess during the so-called posterior tympanotomy, you have access to one of the areas where cholesteatomas might be hiding. By removing the incus and the head of the malleus, then you have a direct line of sight to the anterior epitympanum. And then by taking the incus buttress down, then you have even more exposure over the facial nerve. You can't see into the sinus tympani, but you're close to having the same visualization as canal wall down tympanomastodectomy. So these mastodectomy techniques developed over time. The canal wall up techniques developed over time. So today, where we are, is you have these two basic techniques. Now, having said all that, there's many different varieties where you can remove do an adichotomy, which is kind of like a mini canal wall down, if you will, where you just go from the inside out and you follow where the cholesteatoma goes. And an adichotomy may be all that you have to do with canaloplasty in order to remove the cholesteatoma. So, but the two broad categories are these two procedures. So again, the canal wall up, what you're trying to do is maintain the normal anatomy of the ear canal, try to keep things intact so that you have a better result with the hearing. It's easier to take care of. And in temporal bone classes that you guys have already had, you've already been drilling this. If you're senior residents, you've hopefully been doing these procedures. So canal wall up has these pros and these cons, which are reported in the literature. But we've kind of talked about that some already. But not exposing the entire middle ear cleft really is talking about the sinus tympani. So when we say technically more difficult, it actually is more difficult and is actually more aggressive to be doing canal wall up surgery for cholesteatoma than canal wall down surgery. Canal wall down surgery would be considered even more conservative and should be less difficult technically than canal wall up. So the canal wall down, if you think about historically, it may or may not be the most widely used surgical approach, but over time, if you look at 100 years of otology or longer, it probably actually is probably the more widely used approach over the history of otology for cholesteatoma. There's a couple of keys about canal wall down surgery, is that if you have really extensive disease and you're really not able to get the cholesteatoma out through a canal wall up approach, there's no problem with converting your canal wall up approach to canal wall down approach. So in fact, we'll have situations where we say that there's an enormous amount of posterior ear canal erosion necessitating converting it to canal wall down. Low-hanging tegmen may be another one, anterior sigmoid may be another one. So these are just different ideas that come up when converting from canal wall up, canal wall down. What I like to do is think of it more systematically in terms of when do I convert? And the two most common things that I use to convert is the amount of lateral canal destruction from the cholesteatoma, and also with the anatomy of the mastoid, if it's not allowing you adequate visualization of the areas you need to get into to remove the cholesteatoma. So if either of those two are not in place, then I'll say we need to convert it, we need to do canal wall down, we need to help the patient that way. These are some interesting points about surgical experience. For example, a lot of people, they do temporal bone classes, they do canal wall up surgery in residency, or they're doing fellowships or otologic or neuro-otologic fellowships. They do a lot of canal wall up procedures. But if you think about your canal wall down surgery, you probably need less experience to do a good job with that than you do canal wall up, because you have much more visualization. The procedure itself may be shorter. People think, well, it's going to be longer to do canal wall down, but actually not. It may be shorter to do canal wall down versus canal wall up. There is the cons about it does take a while to heal. So when you have a mastoid cavity, another thing that's really important is a meatoplasty and removal of a crescent of conchoidal cartilage to do a meatoplasty. When you do the meatoplasty, then you're going to really make sure that you have a good opening into the mastoid cavity. But that, having said that, it does take a while for that to heal. Water exposure limits, interesting point. In Florida, we have a lot of people in water. Well, actually, nobody's in water right now, but we have scuba divers, we have swimmers, we have people going to the beach, we have all these people that want to know, well, when can I go back and do what I do? So what we'll do with people is with canal wall up surgery, I try to get them back to their normal water exposure. With canal wall down, I think it's a lot harder to do, but I think if somebody has an excellently healed epithelialized cavity, I think that they do have the opportunity to try to get back to some water exposure. I have a bunch of patients here in Florida that are scuba divers, and with stapes surgery and also with canal wall up surgery, what I'm finding is that a lot of them, or most of them, go back to scuba diving. So hearing interventions, we'll talk about that for a few minutes, and we're at 11:36. So I'll try to wrap this up fairly quickly and see if we have time for questions. I do see a chat question. Oh, okay. So the question is about lateral canal fistula. It's a really good question. So if you have we can talk about it now. So the classic description, or the classic recommendation is canal wall down surgery. This is with the lateral canal fistula, if you know it going in. So typically these people will come in, they'll have vertigo, and then on your CAT scan you can see a lateral canal fistula. So the classic board kind of question and board answer kind of question is you do canal wall down surgery, you leave the matrix in place, and that's the treatment. But a lot of us, what we'll do is we'll suspect a fistula going in, and then as you're dissecting the colesteatoma, when you're in the area of the lateral canal, there comes a point where you say, do they have a fistula or they don't have a fistula? And you're over the lateral canal and you lift up the colesteatoma, and let's just say you find a small fistula. And then, but you've already now opened the fistula. That's kind of what happens a lot of times in colesteatoma surgery. So at that point in time, remove the matrix, leave canal wall up, and then make sure that you patch the fistula. I use a large piece of temporalis fascia and then pack that area. But these people will have vertigo post-op. You have to understand this doesn't necessarily mean they'll have there's a good chance of sensorineural hearing loss. It's not automatic, but they're almost all the ones that I can think of have vertigo. But that does resolve with some rest and some recovery. So I hope that answers the question, Jeffrey. But from a resident perspective, I would still think about your classic canal wall down with leaving the matrix. Okay, so let's talk about hearing. So I'm a huge fan of cartilage. So I found that cartilage is one of the most amazing otologic materials there is. So, what I'm going to do in a lot of these cases is I'm going to work, first of all, to remove the incus. I'm going to remove the head of the malleus. I wrote a paper about removing the entire malleus and presented that at the Academy a few years ago. And I found that my hearing results were the same as published hearing results with the malleus in place. But the classic description is to leave the long handle of the malleus in place, remove the head of the malleus, and then with reconstruction, after you have everything removed, titanium seems to give really good results in the paper that I published. We actually found titanium did better than hydroxyapatite, although we have both ossicular prostheses available. But most of these people are going to have cartilage. And I'm finding that over the years of using this on, I don't know how many hundreds now, but that they heal tremendously well, especially if you use perichondrium as a graft. So if I use tragal, my favorite is tragal cartilage with perichondrium, or I remove the perichondrium but use the cartilage and then graft with the perichondrium as well. I've had my best results with these in these situations. And then we'd be using titanium implants in those situations, PORP or TORP, depending upon what the situation is. So in conclusion, I hope that I haven't been confusing, but I wanted to hit on a couple of key points about acquired cholesteatoma, that there is primary acquired cholesteatoma, as we've discussed in the classic description, but also to think about secondary acquired cholesteatoma, secondary to some event. So if somebody says to me, you have a case of primary acquired cholesteatoma, and you have more cholesteatoma later, is that recurrent or is that residual? Now, my belief is that for the most part, that's residual. So that when we look at myself doing cholesteatoma surgery, I try to explain to patients that I have about 30% chance that there will still be something left. Even in the best of operations, I'm saying to people about 30% will still have cholesteatoma in there. That is not really secondary acquired cholesteatoma. That's still the same process of the primary acquired cholesteatoma. Patient comes in with a perforation, and you look at the edges of the perforation, and they have rolled edges with squamous epithelium rolling around the side and then entering the middle ear cavity and forming pearls perhaps, but this could be keratin debris scattered throughout the middle ear. That's your classic secondary acquired cholesteatoma. Different things, different ways that they behave, but I just wanted to be clear about those descriptions. Cholesteatoma is locally invasive and locally destructive. So structures that are nearby can be injured. And then the definitive treatment is, excuse me, is going to be a surgical approach. So now let me just summarize one last conclusion about second stages. So I do perform second stage operations. I try to individualize these cases. So if I have a patient that comes in with a fairly extensive primary acquired cholesteatoma, that I would say to them, we'll do the surgery, and then I will talk to them afterwards. I think we're going to need to do a second stage. The patients will typically say, okay, whatever you say. But I will also talk to them about diffusion weighted MRI scans. So then when I look at the post-op like recovery, if I'm seeing a patient 6 months post-op and it looks fantastic and their hearing is decent, I'll probably do a diffusion weighted MRI scan. If I look into their ear and I'm seeing, oh, well, there's obviously more cholesteatoma there, then I'm going to do a second stage. So I hope that helps in terms of those are kind of two ends of the spectrum. Now, everything in between does require some ingenuity in terms of like, well, what are you going to, you're going to do the MRI, are you going to do both, or are you going to just operate, or I think that you have to individualize these cases and determine, what your approach is going to be. All right, so I'm at 11, let's see what time it is. We're at 11:44. So I think this is a good time to stop. And then if there's anybody who wants to write questions, that's fine. Or turn on their microphone and ask questions, that's good as well. But I wish all of you the very best, and as we deal with the current situation. But I'm here to take questions if you have them. But thank you for your attention.